patients, or some people don't like that. But I deal with cancer patients, all kinds of cancer patients. And I deal with the morbidities of cancer treatment. So I see all the issues that happen from treatment in the mouth. And that's really what our specialty is. We manage ourselves, or we manage our patients and figure out ways to deal with what now cancer therapy has done to their mouths or how to fix it. So that's really what we do. So I like to think of myself as a cancer dentist. Some people say we're oral oncologists. Some are true professionalisms and true professionals and call themselves maxillofacial prosthodontists, which is technically what I am. But I like cancer dentists. It keeps everybody simple. So I can't start a presentation without talking about MD Anderson. Much like me, it started from humble beginnings in the early 1940s, where this gentleman, I don't know if I have a pointer, I don't think I do, but the bigger picture, that's MD Anderson right there, and he wasn't a doctor, he had nothing to do with cancer other than the fact that he had a bunch of money, which he donated to the guy down below. And basically in an estate in Houston, in an army barracks type of situation, they created this hospital where they started treating these cancer patients. And slowly we moved to the place we are now, and they built a hospital that was all pink marble. And they, for a long time, and you can still see the original building, they called it the Pink Palace, and they still do, because it was just lined in this pink marble. And now we've become this huge cancer hospital that we're the biggest thing in the medical center, and the medical center is the biggest thing in the country, the biggest medical center in the country that we know of. So from very humble beginnings, we've created this metastatic MD Anderson Cancer Hospital, with all different kinds of specialties. There were 6 doctors. That one is one of them down below. But one of the 6 doctors was a dentist. So the dental team has been integral to MD Anderson since day one. We are now 5 dentists strong. We used to be 6. We're looking for an extra doc. If you know of anybody, please send them our way. But certainly from humble beginnings on the Baker estate to now what you see today. Come on. Oh. So we all have to talk about financial disclosures. I have no conflicts of interest, so nobody's paying me to do this, unfortunately. But so I have none of those. So we're going to talk a little bit about guidelines. So what I'm going to present to you today is really not my opinion. It's the opinion of all these different groups, and you can look at them on your own and see what they think and what they've told you and make sure that I've told you the right information. So it's not my opinion necessarily, it's just the conglomeration of what all these groups tell us and tell us is right for our patients. I belong to the International Society of Oral Oncology and MASC, which is the Multinational Association for Supportive Care in Cancer. So this is our guys, and these are all excellent references for patients. So you guys write them down, and if you need them, I'll tell you them again. So as far as managing head and neck cancer, thyroid is technically a head and neck cancer. We have lots of morbidities or lots of things that can happen after radiation therapy. And I've been doing dentistry now for 10 years, and I've been an oral oncologist, a maxillofacial prosthodontist, a cancer dentist now for 5 years. And it never ceases to amaze me how variable patients can be. So we have a study going on now where we see patients at different points in their radiation. And sometimes I'll look at a patient and they're about midway through and they're really sore. They have all kinds of problems. Their mouth are super dry. They have all these sores on their neck, and your heart goes out to them and you try your best to make them feel better. And you know they have so much more to go, and your heart goes to them. And then you see your next patient or the next patient, and it barely looks like they've turned on the machine. You know, their pain is pretty low. Their skin didn't break down at all. It's almost like nothing happened. So there's this huge dichotomy, and we as doctors, as scientists, like to think that every patient's going to react the same way, and these are the things that are going to happen, and these are the things we're going to do for you to make those things better. But not everybody is the same. Patients are different, and so they respond differently to the treatments we give them. Radiation is no exception, and I think it's the most exception you can be, because there's such a huge variability as to what can happen. Like I said, patient A can do really poorly, and patient B can do really great, and we have no idea why. The first paper that's come out, and I didn't bring it up here, but I'll bring it up to you guys, is that there was a paper that came out that said 2 of these major morbidities, one being trismus, and trismus, for those of you who don't know, is the inability to open the mouth. So when the muscles of mastication are in the field of radiation, they scar up. And when they scar up, you can't open your mouth as wide. And the fancy word for that is trismus. The other big thing that can happen is osteoradionecrosis, which is just above there. And that's a bone issue. So when the jawbone's in the field of radiation, it doesn't heal very well, and it can die. And we've always thought it was a blood flow issue. There was one paper out of Great Britain that finally looked at this from a genetic perspective and found that patients that develop these morbidities have a very, very specific genetic makeup. And I think that's super interesting in that if you have a very specific gene, you're more likely to have these issues. And I think that's awesome, and I'm hoping they're going to build on that. But that's certainly what we see. Some patients do super well, and some patients don't. Maybe the ones that are super well don't have this very specific gene, and the ones that don't do as great have a very specific gene. And maybe that'll come into play down the road as we decide how to personalize medicine for cancer patients and how to maybe decrease treatment for these patients that have more likelihood of issue. I'm going to talk about specifically two of these morbidities, one being xerostomia, which is the fancy way of saying dry mouth, and silodinitis, which is basically a salivary gland clog. And we'll talk about that in a minute. So you can't have a conversation about dry mouth and silodinitis without talking about where your salivary glands are. And we have three major salivary glands. The parotids being along the sides here, stemming from almost about the top of your ear here, and wrapped around the edge of your mandible. Those are called the parotid glands, and they drain into the mouth through what we call the Stetson's duct. So if you pull out your cheek, you see kind of a little flap right there, right by your first molar on your upper jaw, and that's basically the drain. Just feeling it. And that's the drain for your parotid gland. And then underneath your chin right here, you have two together. You call the submandibular and the sublingual. Those are smaller. And they drain into the mouth through the Wharton's duct, which is right underneath your tongue. You have two little knobs right there. So they drain in through there. And that's called your Wharton's duct. So during radiation, this is a typical picture for somebody. Granted, anaplastic is a super aggressive disease, so we radiate super aggressively. But this is a pretty typical picture for a patient that's gotten thyroid cancer. And the red is being the high dose at about 70 gray, which is quite a bit of radiation. With the newer technologies, this is IMRT, we can spare certain organs, the parotid glands being one of them, the ones right here we talked about, and we try to minimize the dose to that area as much as possible without sacrificing tumor killing or doing anything like that. So these techniques have changed xerostomia or changed dry mouth quite a bit, but they still happen, and that's still part of the problem. So we have to manage it some way, and we're going to talk about that in a second. So whenever we talk about dry mouth, we always have to look at the literature and see what everybody has said about it. So this is a study we did kind of early on in our career, and these by all my mentors, and we looked at this was in the late 70s. So we took patients, and I think things are cut off on my slide there. Anyway, so we took patients at day 0 right before treatment, and they went through 7 weeks of radiation, and you can see that's salivary flow going from 1.1 all the way down to really low. And at 3 years, it was at its lowest. But the interesting part about this is that not every patient experiences this way. So patients will say, oh yeah, it was at worst during treatment, but after treatment it got a little bit better. So that's what we hear all the time. And subjectively, that's what we find out. Patients will be dry during treatment and it gets better in their own kind of perception of it. And for our patients, perception is reality, which is great. But all the protective features that saliva have are decreased for sure. So we have to take that into account. Because of these kinds of things, this is where now we've developed MRT or taken advantage of IMRT and tried to spare the salivary glands as much as possible. Because we know if we spare the salivary glands to less than 25 gray, they'll still work, which is great. And so this is external beam radiation. So the picture that I showed you with red. Forgot a slide here. Hang on. So because of dry mouth, things like this happen. And this is basically dental caries. As a dentist, I basically treat two things. I treat periodontal disease, which is an issue of the gums, and I treat caries, which is basically cavities. Those are the two things. Arguably, I would treat trauma too, dental trauma. But this is basically a third of my practice, dental cavities. And in a dry mouth, these teeth will not hold up. Again, all the protective features that saliva have are now gone. So teeth are more likely to decay. We have a higher incidence of bacteria, bad bacteria in the mouth, that can cause a whole lot of issues. So we have to do something about this. And what we do is fluoride. Fluoride gets a bad rap on the internet only. So if you Google fluoride therapy, I'm sure you're going to find a couple of so-called articles by people that say that fluoride is bad and it's causing autism and it's causing all of these cancers and all these things. We don't seem to think that way, and we'll talk about that in a second. But certainly caries are a big issue, and especially the biggest problem is where they form. Caries in a dry mouth will form around the root surface. And as a dentist, that's problematic. One, because it's hard to get to. They're just near the gums. If you make the gums bleed, then you have an isolation issue, especially with our tooth-colored restorative materials. So if I were to put in metal, like an amalgam or a gold or something like that, no issue. Those tend to work a little bit better. But nobody really wants a big metal filling on your front tooth. I wouldn't want that either. So bonding on root surfaces is kind of hard. Now, bonding on the smooth surfaces in between teeth and bonding on the little peaks and valleys or the occlusal surface of teeth, those are fine. But those are basically the three places we can get cavities. So on the root surface, on the smooth surface in between teeth, and on the root surface right near the gums. Now, when you can see that picture, that's a real tooth sectioned with a cavity on it. You can see it had a cavity in between the teeth, so right where the two teeth met. And that cavity went right through into that little space right here. So right in here. And in these spaces, that's basically your nerve. So when the cavity, which is basically an infection that's decaying your tooth, hits that nerve, it'll also infect your nerve, and then the nerve can't really heal, and the nerve will die. And that's when you'll need a root canal. And then when the nerve dies, it'll spread out into the bone around the tooth, and that's what really, really hurts, because what typically happens in an infection is the body needs to swell to try to heal it, but bone doesn't swell, and teeth don't move. So that's what hurts. Hurts like hell. So we have to go in, cut off the top of that tooth, basically have access to that nerve, and clean it out. And that's when our patients feel a whole lot better. We get rid of that inflammation, and we allow the tissue to heal. Once we've created the space by taking the nerve out of that tooth, we have to fill it. And that's with our gutta percha material, our rubber material, and that's basically a root canal. That's endodontics explained as simply as I can. But that's basically the bottom line. So, we all know that sugar causes cavities, but we don't know really how. I think that's at least described. It was described to me as a little kid about, how sugar causes cavities and how if you eat too much sugar, it'll give you a whole lot of cavities. And that's not necessarily true. It has nothing to do with actual quantity of sugar. It has to do with frequency of sugar. So I have a cup of coffee here, which I do for my dry mouth when I talk to y'all. If this had a whole bunch of sugar in it, I take a sip of sugar, I swallow it, and it's gone. But the residue is still in my mouth. And because our mouths are not sterile, not my mouth, not your mouth, not anybody's mouth, there's bacteria in there. They'll eat that same sugar with me. But when they eat it, they'll produce an acid. And it's that acid that destroys teeth. So now we have two things. We have a tooth that's, we have sugar that you're eating and a bacteria that we can't control, and a substrate, which is our tooth. So we have those three things. So bacteria, sugar, and a substrate. We can't really control the substrate unless we take your teeth out. So that's a bad idea. Nobody wants to take teeth out, right? We can't control our bacteria. We can't get rid of it. It's always there. We can't sterilize your mouths, unfortunately. And now we have this acid that's destroying the teeth. So our two best bets to controlling cavities are reducing bacteria, not really getting rid of it, but at least minimizing how many are there, and reducing some of the acids. So those are our two major points. That's what we can do. The other option would be take the teeth out. And we found that if we take all your teeth out, the bacteria go away, which is really strange. So we'll take teeth out, and we culture the mouth, all the bad bacteria go away. Really weird. But then the second we put teeth back in, whether they be prosthetic or any kind of prosthetic, ceramic, plastic, metal, you name it, as soon as we put teeth back in, all those bacteria come back. It's really weird. It's the weirdest thing ever. Because, and what makes it even more weird is when we're all born, our mouths are sterile. So in the womb, our mouths are sterile. And the second we come out, we get these bacteria, we don't know where they come from. Some argue that it's the mother. So the mother passes on the bacteria to the baby. So they do all this talk about not putting pacifiers in your mouth before you put it into the baby's mouth, that kind of stuff. But basically the bacteria are there and we can't get rid of them. So what I mean by quantity versus frequency, I got sidetracked there. So when I take that sugar, that acid goes up in my mouth. And then my saliva comes in and neutralizes that acid within several minutes. And that's awesome, because my saliva works and everybody's happy. But if my saliva doesn't work as well because of radiation or because of radioactive iodine, now we have a problem, because my teeth will be exposed to acid for a whole lot longer period of time. And that's what starts to decay teeth. But now the problem is, with the dry mouth patient, most of the time, you're sipping on something to make your mouth feel better. So now I'm going to take another sip of my coffee. So my mouth is already acidic, and I'm taking a second sip. So now my acids in my mouth is going up even higher. So that's what I really mean. So if I just took this 20-ounce cup of coffee and basically chugged it, that's one exposure, as opposed to, let's say, I drink an ounce or swallow an ounce at a time, and I drink 20 sips of it all throughout the day. Now my teeth have been exposed 20 times to the same acid. Does that make sense to y'all? You following me? So that's the deal. I knew this slide was coming up somewhere. So what about radioactive iodine? And again, this was an early study by my mentors in the early 90s. We looked at radioactive iodine, and we knew those patients had a higher risk of cavities or caries. So we thought, well, maybe it's just increased bacteria. And that's true. They have increased bacteria, but not a whole lot. But their mouths are pretty dry. They dry out after radioactive iodine. And this is one of the first papers that actually kind of showed that and discussed that. And I think a lecture I heard yesterday, but I forgot who the person was, from the University of Chicago, he said 60% complain of dry mouth after radioactive iodine. I see a lot of nods out there. But for some reason, it always gets ignored. It always gets ignored. And I don't know why that is. Dentistry is always kind of the forgotten stepchild in the medical field. And as oral oncologists or as maxillofacial prosthodontists, we try to, scream loudly for y'all. But certainly this is a huge issue. And as far as the radioactive iodine, we have two. Hang on. Let me take a second here. So this is basically patients that we caught before they had radioactive iodine and after radioactive iodine. And we saw about a 30% decrease in their overall salivary production. So hugely significant. Now, what's even more interesting is that of the 60% that we told you were going to complain after radioactive iodine of dry mouth, like I said, is very subjective, which means it has nothing to do with actual quantity. So of these patients that are in this group, not necessarily all of them complained of dry mouth. So we know there's an objective decrease in saliva, but not everybody's going to complain, or not everybody's going to notice maybe. So that 60% on the study that I heard yesterday may be grossly under-exaggerated or underreported only because patients aren't noticing, or maybe didn't think to say anything, or maybe they just don't plain notice. That happens. Their saliva may be dry. I may look in there and go, God, your mouth is real dry. And I ask them, hey, is your mouth dry? No. So, it's hard to say. It's hard to say. So there's been studies about radioactive iodine, and we know it goes directly to those salivary glands, and we don't know why, but they sure do. About 24% goes directly to those salivary glands. And then two major things happen once that happens. So radioactive iodine gets into the gland itself and does damage to the highly differentiated salivary glands, the serous gland, or the serous cells, excuse me. And it's those serous cells that are responsible for doing all the fancy smancy stuff that saliva does. And some of the fancy schmancy stuff it does is mitigate those acids, control bacteria, remineralize teeth. So those cells are now destroyed. Now on top of that, with the radioactive iodine, as it gets secreted through those ducts, the Stenson duct and Wharton's duct, it does damage to those ducts on the way out too. So it tends to tighten them up. It tends to scar them up quite aggressively, and then we get something called silodinitis, which is a fancy word for the parotid gland, or the glands swell, and there's no drain, so the duct gets clogged on the way out, whether that be from mucus, whether that just be debris, whether that just be stenosis, which means the gland, or not the gland, but the duct gets really tight. So those are things we have to manage, and we'll talk about that in a second. So we have prevention methods, and this seems to be somewhat controversial. Some places will do this, some places won't. But things to stimulate salivary flow during radioactive iodine seems to be important, getting the active iodine out of the salivary gland. So things like lemon candy, chewing gum, hydration, simple hydration. Those are all things that some institutions use. I saw some papers that said that if you do this too soon, you tend to increase the amount of dry mouth. The jury is still out, as far as I can tell, about this. And it's not standardized, but certainly an option, something to think about, and something to bring up if you have to go through radioactive iodine to your docs. But certainly dry mouth is going to be part of the deal. So this is a gentleman that's received radioactive iodine several years ago, and that's basically the picture we see in salidinitis. So in this very specific gentleman, his duct was clogged, his parotid, his Stenson's duct. And after he ate, this is what he looked like. So when you eat, it stimulates salivary function, and I see a lot of nodding. That's crazy. All right. You have salivary production and stimulation, basically. And it has no place to go because now the duct is clogged. So it's basically your pipes are clogged up. So for a long time we advocated parotid massage. But if your so-called pipe is clogged, it's not going to go anywhere. You're just trying to push it through this really, really tight, let's say, tube. And that doesn't work very well. The one thing that they did mention in these papers is that the effects of active iodine, again, are two different ones, and they're independent of each other, meaning it has direct damage to the salivary gland and it has direct damage to the duct, and they're not dependent on each other. They can happen separately. So as far as treatment, again, these people tend to advocate the sour candies and the lemon drops and parotid massage during radioactive iodine to, again, get this out of the salivary gland. But again, this is somewhat controversial in the sense that not every institution does this. And again, there's a paper that contradicts this that says that if you do this too soon, it'll lead to more salivary gland damage. So it's really, again, not well studied and not and the jury's basically still out. So what do? The best thing we can do is prevent. So we know we're going to have dental issues in dry mouth, so we have to prevent. That's the best way to manage complications. I think the old adage that an ounce of prevention is worth a pound of cure stands true, especially in dental. You know what I mean? Teeth are the hardest things in our mouths. And there's nothing I can do as a maxillofacial prosthodontist to replace your teeth that are going to do as well as natural teeth work. We haven't gotten there. We've gotten pretty close with implants. That's the closest we've gotten to replace a tooth successfully. But it's still not your natural teeth. They don't work the same way. They're managed very differently. The bite changes completely. So it's better to preserve what's there than to replace what's missing. So that's where we have to start, is prevention. Prevention, prevention, prevention. And these are not uncommon pictures. We see them occasionally in the dental service where I work. So the picture on the right there, that's basically those teeth have now decayed. All the brown is pretty much cavity. So if I put in a sharp instrument, I can go right through. And all the white stuff around it is plaque and tartar. And that's basically one of the three things that we have to control, right? So plaque is all it is a network of bacteria. And plaque is really interesting. We tend not to, but the one thing I want to say is by the time we see plaque, it's 1 billion strong. So for us to see plaque, there's 1 billion bacteria in there. And the way plaque works, and again, super interesting. Again, I'm a dentist, maybe I'm just biased, but super interesting the way plaque works is that good bacteria, what we call good bacteria is bacteria that won't cause a problem, will come in first, kind of very under the radar. So this good bacteria will come in and create a network of its own, and it won't cause a problem for a while. But then for some reason, once that groundwork is laid down, all this bad bacteria comes in. And it's the bad bacteria that we have to worry about because they're the ones that are going to cause a problem. So that's where our cavities come from. Yes, ma'am?
With these slides, do you know if these patients had good oral hygiene?
No. These people had bad oral hygiene, and that's the point.
Okay.
That's the point. So, and again, nothing changes after cancer. If you had bad oral hygiene before cancer, chances are you're going to have bad oral hygiene after cancer. And now all of a sudden you have a reason. So I hear that quite a bit. Oh, my cancer caused this bad tooth issue. Yes and no. Cancer didn't help it any, but the fact that you haven't run a brush through these teeth in a couple of weeks, that helped. That helped quite a bit. So I tend to shoot straight from the hip, so if you guys don't like that, I apologize. But yeah, that's true. These people had bad oral hygiene. They had bad prosthetic hygiene, so that means that man never took out his dentures, the one on the left. So he had a lot of fungus and a lot of crud growing, basically. That's a very sophisticated dental term. Don't go throwing that one around. And so things like sores and tongue sores all become more obvious because, again, we have dry mouth, more bacteria, more issues. And everybody kind of gets grossed out by this, and it's true. There's more bacteria in your mouth than there is in your intestines. And this, I can never pronounce this German guy's name. I couldn't pronounce it yesterday, and I can't pronounce it today. And every time I give this lecture, I still can't pronounce it. But this, any Germans in there? There you go. I'll forget in 2 minutes. Gesellschaft. So he said there's more bacteria in a person's mouth than there are people in the world. And that to me is mind-boggling. Mind-boggling. So tack on a little dry mouth, and these numbers skyrocket. So quite interesting. But not only do we have bacteria in there, we also have fungus. And again, kind of unusual. In a certain, there's this fungus that's there, that's in everybody's mouths, your mouths, my mouths, babies' mouths, adult mouths, old people's mouths. It's there, but when it overgrows past a certain level, it becomes pathogenic, which means after a certain number of them, they kind of all gang up and create all these issues. And that's basically what happened with that edentulous patient, the patient without any teeth, where the fungus grew out of control and now it becomes an issue. So think about that. So what happens after dry mouth about bacteria? So remember I said there's good bacteria that doesn't cause any problems, and there's bad bacteria that causes a whole lot of problems. The one we fight the most is the Strep Mutans. And the reason for that is that's the one that's most associated with cavities. So Strep Mutans has to be there for us to have a cavity. Just doesn't exist without it. If we somehow could eliminate that one very specific one from our mouths, we'd be all cavity-free, but that has not happened yet. We can't control it. And it has something to do with teeth or some sort of prosthesis being in the mouth. Because if I take all your teeth out, Strep Mutans goes with them. But the second I put something back in, Strep Mutans comes back. Really weird. Lactobacillus is the primary guy in periodontal disease. So periodontal disease is basically an inflammation of the gums. And if that gum stays inflamed entirely too long, the body tries to fight off that bacteria by sending out mediators to get rid of the bacteria. The problem is it gets rid of the bone along with it. So that's what periodontal disease is. The body's trying to fight off an infection, sending out chemicals to get rid of it, but in the process kills itself or gets rid of itself. And that's what periodontal disease is. If you let it go on for too long, the bone will eventually go away and the teeth become loose. That's basically what happens. The second we remove bacteria and keep oral hygiene in check, the bone stops, the bone resorption stops, but it never comes back. Big problem. So in a dry mouth, all these bacteria go up. Candida is that fungus I was telling you about. That's in everybody's mouth, but after a certain level, it becomes pathogenic. And then yeast and all the other gross stuff. And we know that all the good bacteria goes down. We subscribe to the matter, one thing can occupy one space in the mouth. So bacteria is going to be in the mouth. We know that for sure. There's no way to sterilize anybody's mouth. It just doesn't happen. So all we can do is populate the good bacteria that doesn't cause any issues and keep the bad bacteria out, because once good bacteria has populated a space, bad bacteria can't come in. It won't occupy that much space. So we always want to keep good bacteria in, and we haven't figured that out yet. So the effects of oral decontamination, that's a fancy word for keeping your teeth clean, have been discussed, and we all know that keeping your teeth clean is never a bad idea. So things like chlorhexidine rinses, when especially in very particularly ooky mouths, as a dentist, this is my first place to start to get bacteria levels down and reduce them. So chlorhexidine is awesome because it has something called substantivity. It's a prescription, so a dentist has to say that you need this. Substantivity basically means that it stays in the mouth for about 12 hours and works and keeps maintaining bacteria levels, keeping them low. So that's great. The hugest downfall to this is that it stains the piss out of your teeth. So if you're not an autumn, if brown doesn't go well with your face, then this is not a great thing to be on long term. Yes, ma'am?
Will it stain crowns?
Yes. Yes. But it's not
I have it at home, but I don't use it.
It does stain. It's not, again, it controls bacteria and it does a really good job of that, but it stains your teeth. So we don't want to be on it for too long. It's a superficial stain, for sure. So that means a hygienist can come in and scrape it all off and it's gone. It's like it never happened. But it'll stain. So good thing to be on short term. And some have even advocated this for prosthesis care. Even as a prosthodontist, which is technically what I am partially, We don't do a very good job of telling patients how to take care of their dentures. We just kind of assume they know. But that's not always the case, because inevitably somebody will come back with kind of ooky mouth syndrome. Again, very technical term. Don't go throwing that one around. Because they don't take their dentures out at night, they don't clean them, they don't know how to clean them. Those are all things we need to do a better job of doing. Yes, ma'am?
So a regular mouthwash is just kind of a temporary,
Medi-
until you have a cup of coffee or something with sugar,
Mouthwash, traditional mouthwash that you find over the counter, Listerine, Crest, whatever, you name it. The second you spit it out, it's gone. All the effects are gone. So while it's in there, it'll continue to kill bacteria, which is great. But the second you spit it out, gone. Absolutely gone. Yes, ma'am.
what about things like biotine?
Biotine, all that is a mouth lubricant. And it's great if that's what you're trying to do, lubricate your mouth. But as far as controlling bacteria, controlling cavities, reducing those risks, nothing. Nothing. Yes, sir?
So since things like Listerine can dry your mouth out more,
They will.
would you work out to do Listerine and biotine?
No. No. We're not a huge fan of alcohol-based anything. And all the traditional mouthwashes are really, even the alcohol-free ones, we're not huge fans because they don't work as well as we want them to. We like chlorhexidine, even though it is alcohol-based, because it has substantivity, which means it'll last a long time. Listerine, well, the second you spit it out, gone, and bacteria is coming back. So it's not quite as effective as everybody likes to say it is. All the 99% bacteria is great, but the second you spit it out, it's gone. So we don't like alcohol-based mouthwashes, especially in the dry mouth, because that tends to dry it out even more, unless you're getting a better benefit from it, which is this. So again, you're weighing the pros and the cons here. So he stole my thunder, because that was going to be my next thing. No alcohol-based mouthwashes, especially in the dry mouth. I don't like mouthwashes at all, period. Because I don't think they do everything they're supposed to. I don't think a over-the-counter mouthwash has a role in daily oral hygiene practice of anybody, especially the dry mouth patient, because the alcohol will make it worse. The alcohol will make dry mouth worse. And you'll notice on the lower right there's a hydrogen peroxide. We also don't like that because it tends to burn, especially in a dry mouth. So bad idea. Bad idea with the dry mouth especially. What we recommend, and this sounds, I always get a weird look when I say this, we recommend baking soda rinses. Why? Because it'll flush bacteria out, which is great, and then it controls the acid. So remember, to have a cavity, you need three things: acid, a place to have a cavity, and bacteria. So what sodium bicarbonate does is reduces some of that acid. So it's cheap, it's easy, it's effective. Why would you spend $6 on whatever Oral Pro Health Sensodyne stuff when you got a pretty effective mouthwash at home, probably sitting in your refrigerator right as we speak? So it's the perfect thing. Perfect thing. Some patients don't like that because it doesn't taste like anything. They enjoy the fresh, minty taste that Listerine gives them, or whatever. I don't mean to be hitting on Listerine. That mouthwashes give them. So when I say that, I say try to find something that has fluoride in it. So a fluoride rinse makes a huge difference sometimes. So the only one that I'm aware of is ACT. There may be more than that. And what that is basically a fluoride rinse. It has the fresh, minty taste that everybody's craving. So you rinse with that for about 30 seconds to a minute. You spit it out. And you can't rinse, eat, or drink for 30 minutes after, and that allows the fluoride to make its way into the tooth. So if you need something just to rinse out and make yourself feel better, a fluoride rinse will work. I'm sorry? For the baking soda? About a teaspoon? Teaspoon of baking soda to about 20 ounces. 20 ounces. I'm sorry, hang on to that thought. Rinse about 30 seconds. Yeah, 30 seconds to a minute. So a little bit. Yes, ma'am. Yes, ma'am. Baking soda toothpaste, what you buy over the counter, is okay. Now, using baking soda as a toothpaste, straight baking soda, is a bad idea. Why? Because baking soda is super abrasive. So it'll destroy your teeth pretty quickly. So baking soda as a toothpaste, straight baking soda out of the box, is a bad idea. But a baking soda toothpaste is okay because it's been diluted enough that it's not very abrasive. So that's all a whitening toothpaste is. whitening toothpastes have silica in it, which are basically glass beads. So a whitening toothpaste, the way it whitens is by taking off kind of these surface stains that we were talking about. Baking soda toothpaste is no different than that. It's basically an abrasive in the toothpaste. So it's at levels that are not detrimental. Yes, ma'am?
Would you bring that solution up and keep it through the day, or does it have to be made fresh?
No, you can keep it. You can keep it in a jar, and that's what we recommend for our patients, that they just mix it up, and however long it takes you to get through that bottle is however long it takes you to get through the bottle. Some patients will refrigerate it just to keep it fresh. Sometimes if it's too cold, it'll hurt your teeth, so they keep it just out, make sure it's covered. So it doesn't have to be mixed fresh every single day. Make sure you wash out the bottle. There's an interesting story of a patient that I saw that kept getting these recurrent fungal infections after radiation, and we couldn't figure out why. Every time we'd culture, it'd be like this huge kind of fungal contamination. I'd give her all kinds of antifungals. And then one day I looked at her water bottle, and it was kind of cloudy. And I'm like, what's going on with this water bottle? She's like, I don't know. It turns like that after a while. I'm like, how long have you used this one? She's like, since I've gotten radiated. I'm like, that's probably a bad idea. So clean the water bottle. That makes a huge difference. So just FYI. So fluoride, again, bad rap on the internet. But as dentists, we think fluoride is awesome. We can't say enough about fluoride. And the way we found out fluoride even works was kind of almost by accident. So we knew there was a group of people, I think out in Colorado and a bunch of different states, this all kind of happened independently, where kids and people just had brown teeth. We didn't know why, but they were super hard. So they didn't have cavities, but they were just brown. So they did some analysis on the water, and they found that there was high levels of fluoride naturally in the water. Nobody put it there. It was just there. So that's why they had, when they drank water, it would integrate into their bones, it would integrate into their teeth, and they created this mottled, ugly enamel, but they were super hard. No cavities. Didn't matter. It almost made no difference whether their hygiene was good or bad. There was no cavities. So then they started studying it, and they realized that that was part of fluoride, and then they knew that fluoridated teeth that had fluoride in them were much harder. So then they started putting them in at lower levels. And now it's in New York City, I know it's 1 part per million. I think every city establishes what they are, but they know that if a little kid is exposed to fluoride in their teeth-forming years, those teeth are much more resistant to acids. And what we find is that if it's integrated into the tooth, it's way better. Once we're adults, teeth don't change that drastically. Teeth aren't forming anymore, but if we put it on topically, it works kind of the same way, where fluoride makes its way into the crystal structure of the tooth and makes that crystal much more resistant to acids. Again, that's exactly what we're fighting. So again, we're controlling that acid, or controlling the substrate now. So by reducing the effect of the acid on the tooth, we're keeping your teeth a whole lot more strong. So that's why we love fluoride. Again, what you'll find on the internet, if you Google fluoride, you'll find all these bad things about fluoride. And again, grossly exaggerated because they're talking about super high doses. And we're not talking about giving you super high doses. We're talking about giving you 1 part per million, which is not a lot. We're talking about 1% sodium fluoride, and that's a prescription. So we're not talking about a whole lot of fluoride. And once you do it topically, you're really not ingesting it. So it's on the teeth, you spit it out. So not a big deal. So we know it incorporates into the crystal structure of teeth, making it a whole lot more resistant to acids. Now, we have 2 different kinds of fluoride, generally speaking. We have a sodium fluoride, which is what's in everybody's toothpaste. And generic toothpaste, or toothpaste that's available over the counter, that's about a 2.2% sodium fluoride. Prescription toothpaste, or the Prevenant 5000 Plus, or the Clean Pro, or whatever a dentist would prescribe, that's 1% sodium fluoride. So that means it's a neutral thing. It's just fluoride. You leave it in the mouth for about 30 minutes. It makes its way into the tooth, and everybody's happy. Now, with stannous fluoride, that's kind of our second option. Stannous fluoride is actually a little bit acidic, and that's on purpose. Because if you demineralize a tooth just a little bit, when it tries to remineralize, the fluoride will make its way in much more effectively. So we like that. Not everybody can handle an acidulated fluoride like that, but it's certainly an option. And on top of that, with the acidulated fluorides, we have the added benefit of killing some bacteria, which is great. So now we have a twofer with the stannous fluoride. We kill some of the bacteria, number 1. Number 2, it makes its way into the tooth a whole lot more effectively. So we like the stannous fluoride. The stannous fluoride is available over the counter, at least in Texas. I can't speak for Colorado. Maybe a prescription here. But in Texas, it's over the counter, so anybody can go to their Walgreens and say, hey, I need a box of stannous fluoride, and you can have it. So oral care, this stands for everybody almost. With dry mouth, we just have our battles a little more uphill. So using sialagogues. Sialagogues is a fancy schmancy word for anything that substitutes saliva. So saliva substitutes. So if you have some dry mouth, a salivary substitute isn't a bad idea. And that's the biotine we're talking about. But biotine, all it'll really do is make the mouth feel better. That's all it'll do. Things like fluoride treatments, especially in the dry mouth, super important. Even as dentists, when we restore a patient, these big veneer cases, Regis Philbin has 28 or 32 or 75 different veneers in his mouth, all toilet bowl white. When you do that kind of work, you're adding a lot more places for cavities to start. Luckily, he's got lots of money, and hopefully somebody brushes his teeth for him occasionally, so he may not have so much issue. But any big case like that, fluoride benefits, because now we've created margins and places for decay to start. So any big reconstruction in the mouth, when there's teeth involved, should have some fluoride part of it. Things like 3 to 6 month recalls are important. So we recommend everybody get at least a 6 month, and I'm okay with that. And I tell all our radiation patients, all our radioactive iodine patients, that every 6 months is okay. But if every time you go to the dentist, you're having a lot of issues, maybe it's time to step it up to every 4 months or every 3 months. If you're on a 3-month protocol and you really don't have that many issues, things are going well, you don't have lots of cavities, then maybe it's time to downgrade. So you have to there's no such thing as one size fits all. So at least every 6, with issues, every 3. Does that make sense to y'all? Of course, cleaning, effective prosthodontic rehabilitation is always a big deal. So if we've taken your teeth because of radiation, we have to do our best to put them back. Radiation tends to limit those things sometimes, but we do our best to replace it. Dental restorations is needed, oral hygiene, oral hygiene, oral hygiene. Surgery after radiation is a big deal. Now, most of our thyroid patients, the jaws aren't really in the field of radiation. So for thyroid, we don't worry about it too much. It's the throat cancers and the oral cancers that we really get super concerned about, because if the jawbone is in the field of radiation, sometimes it doesn't heal very well after surgery. So if we pull a tooth in an area that got lots of radiation, the likelihood is that it's not going to heal. So we have to worry about that. So oral surgery after radiation is important. Again, not so much in thyroid, but all the other cancers it is. So something to consider, even after any kind of radiation. Does that make sense to y'all? So xerostomia. I have no silver bullet for xerostomia. I'll be upfront about that. I have no way to make it, super better. I can manage it. I can give you a couple of tricks. We have a couple of things we're looking into, which we'll talk about in a second. But I have no way to make it better, make it go away. So we always start with simple stuff. So increased baking soda rinses, increased hydration is always where I start. And that's what I'll tell everybody. When they come to me and they say, hey, I have a lot of dry mouth, and I say, hey, how often do you rinse? And so most of the time they'll say, never. I haven't done baking soda since my last radiation treatment. I'm like, well, maybe now's a good time to start back up and see how you do. And most of the time that resolves the issues. Now on top of, if that doesn't work, then I start recommending biotines. And those, I have no one brand. And this was interesting because I say it to everybody, and yesterday it happened right in front of me when I gave this lecture yesterday. I had 2 ladies right next to me. One was like, oh, biotine this, biotine that. I do biotine all the time. And then the one lady right next to her was like, I hate biotine. It burns my mouth, and it does this, and it does that. So there's no way to know. So what I recommend to y'all is go to Walgreens, go to Walmart, go wherever. See what is available, and basically pick 1 or 2 and see which one works for you. Because they're all just a little bit different. We make several recommendations. We like the biotine because that's the most popular one, the easiest one to find, so we'll always whip that one out the first. Things like Medactive is nice. Medactive, its claim to fame is that it has something called spilanthes in it. And that's some sort of herbal regimen that's supposed to stimulate salivary flow. So we like Medactive. Somewhat hard to find. I know Walgreens carries it, but not all of them. Oasis has one. Yes, ma'am. Medactive, Medactive. So med, like medical, and then active, like physically active. And they make all kinds of stuff. And it's not, they all make sprays, and they all make lozenges, they all make gels. We like the gel in particular, especially for patients that have dry mouth in the middle of the night. So they wake up with dry mouth. What I'll tell our patients that have dry mouth in the middle of the night is to use some of that gel on their tongue right before they go to bed. And that tends to coat the mouth and keep it more comfortable longer. hopefully all night long. So that gel, whichever brand it is, it works really well. If that's still doesn't work, then we start talking about acupuncture, and that's our newest addition to this list. We did a study out in Fudan University, or in conjunction with Fudan University. Again, super small study, only about 20 patients, and I think I'm skipping a slide here, but we looked at 20 patients, and they had radiation, and they had dry mouth, or at least they complained of it, and we did, well, not we, but the acupuncturist did a very specific sequence of acupuncture points called the 13 points of Nim Chow. And that's how you spell Nim Chow, because I wouldn't be able to spell it myself. And I know one of them is the top of the head, and I think one of them is actually the foot. But done in that sequence, it tends to make dry mouth feel better. Now, objectively, meaning we measured their saliva, we didn't see much difference. But patients reported feeling better. So if it improved their feeling of their dry mouth, we're all about it. So again, super small study. We don't know if we didn't see any increase in saliva because we picked the 20 people that didn't respond very well. So we've actually increased our study, and we brought it to Anderson now, and we're in the middle of a huge study, I think something like 500 or 600 patients, all in all different stages of radiation, meaning they start before radiation, some have started after radiation, immediately after, some have started several years after radiation. And the jury is still out, but my perception is that some patients like it, some patients don't. And it's kind of weird, because I have patients come back that I've sent to acupuncture, and they come back and they're like, oh, doc, it's the best thing in the world. It controlled my pain, and I feel so much better, and everybody's happy. And then I have other patients that are like, I don't know, all I did was shove a bunch of needles in me. It doesn't help any. So I don't know what the results are going to be. But I have patients coming back from those studies are kind of giving me mixed feelings. But the overall perception is that it tends to make the mouth feel better overall. If that still doesn't work, again, we try to spare the products as much as we can. That's during radiation. So we always try to do that. That's part of everybody. But we'll whip out a medicine if we have to. So there's two major ones on the market. One is pilocarpine, one is Selective. And those are basically supposed to stimulate salivary flow. The problem is, and the reason we don't give this to every single person that walks in the door, is one, they're not super effective, especially after radiation, and two, there's a lot of heart issues that go along with them. So we're not huge fans of those, but we will take them out if necessary. But not huge fans. So again, this is where I think I skipped a slide a bit. But with Fudan University, in conjunction with Fudan University, we looked at 19 patients in this very specific sequence, and subjectively they improved, meaning they felt better. But objectively, we didn't really see too much of a difference. So we've increased the study. We're hoping that we just got a bad group, and maybe there is some increase. But I think overall, if we find an overall increase in their subjective opinion about their dry mouth, then maybe it's worth doing. So now a little bit about salidinitis. So that's, again, if you remember, that's when this parotid gets real swollen and the ducts get clogged, right? So we thought to ourselves, well, not us, I think in medicine in general, thought to ourselves, well, if we can open up the duct and clean it out, maybe the salidinitis will help. And that's all salidendoscopy is. Yeah, I see some shaking. She's stealing my thunder. I can feel it now. She's stealing my thunder. So if we can go in, clean it up, it may make a huge difference. So we're looking at that. And our study isn't totally finished yet. So far what I have is 19 patients. I know that has increased in the last several years since I've gotten this. Well, not several years, but maybe the last year. You're shaking your head, and it's true. The overall is that if you had a clog, we can get rid of the clog and make it feel better, but we're not really getting rid of why the clog was there to start. So we're really not dealing with the etiology, we're dealing with the effect. Overall, most of our patients, this is the kind of the typical picture that they complain about. They all complained of dry mouth, they all complained of pain, they all complained of gland swelling, and then a bunch of other things, trismus, infections, blah, blah, blah. All the things you would expect with dry mouth. Yes, ma'am.
Could you do the slide just before that here?
Yes, ma'am.
What was the Hashimoto's?
Thyroiditis. So that was basically a patient that had thyroiditis, Hashimoto's, which is a kind of hypothyroidism, and he or she had this kind of issue. So they didn't have radioactive iodine, they just had thyroiditis. So we didn't only include patients that had radioactive iodine only. We included some patients that had external beam radiation, and we included some patients that didn't have thyroid issues at all, just had parotid clogs, which I guess happens somewhat. So again, they complained of all these things, and what we would do is basically go in like a little rotor-rooter with a camera, see what was there, clean out any clogs, dilate the duct with different kinds of needles, so make it bigger. We would irrigate it, debride it, which basically is fancy for clean it up. We'd do a steroid injection, get rid of some of the inflammation, and then leave a stent in there for several weeks. So we thought we were geniuses. And we were like, this is going to work awesome. And this is the kind of thing that you would see. So these here on the left, they're all different sizes. It's hard to see this far away. But when you look at them, you can see they're much different sizes. And you basically put in different sized needles or dilators and try to expand the tube. And again, these aren't great pictures, but that on the left is a normal salivary gland duct. And you can see it's pink and healthy, and the opening is patent, which means there's a big opening in there. And then the one on the right is after radioactive iodine. So you can see there's a clog in there, so that's basically a mucus plug, and all it is kind of like crud in the duct. And on top of that, you can tell the picture, it's not projecting super well, but you can see on the left it's nice and pink and patent. On the right, it's kind of bleached, is what they call it, kind of pale and a little sickly, the opening isn't as wide. So that's really what we're trying to do, and try to go through this process where we make that duct bigger again to try to at least let it to drain, right? So we would remove all the debris. We had like a little fancy wire basket that got it out. We just kind of washed it out, and we basically get to the gland, and we thought we were geniuses. And we placed the little duct in there for this, just to orient you. So on the right is the cheek, and for those of you that are close enough, you can see the little tube that's in your Stenson's duct. Those are the upper teeth right there, and this big thing right here is the tongue. So initially, we saw some resolution, meaning, and to start, most of our patients felt better. But what we're finding over long term is it doesn't quite work, because we're not dealing with the etiology. The etiology is there, and dilating the duct and making it bigger inevitably doesn't deal with the situation. It's just kind of dealing with it for now. So what we kind of found is that if you had a clog and we got rid of it, that made it better. But as far as treating your dry mouth, not so much. Not so much. And our study isn't complete yet, as far as I understand it. There's one study that just got accepted in head and neck, I forget what it's called, the Journal of Head and Neck Surgery, that kind of corroborated that, which said that over the long term didn't really make a huge difference unless you had the clog. Getting rid of the clog made a huge difference. No. Okay. So some had some response, again, initially in this preliminary data. But again, long term, we don't think we saw that great of a response. The good thing was we did no harm, which meant they weren't worse off once we were done. So I guess in that sense, it was worth a shot. There was no really major complications, which is great, and I'm sure that's going to be surgeon dependent. In the 19 people that we looked at, nothing worse happened because of what we've done. So there's really no injury, nothing like that. And again, we're looking at the goals, but not so much. So to conclude, prevention is the best way. So teaching you guys is the best option I have at this point about what the issues are and how to manage them. Selective decontamination, which is a fancy word for brush your teeth, that helps. That helps a lot. More than you think. More than you think. And again, we fight this battle, particularly when I don't see them beforehand, because patients come in with issues. The normal population has dental cavities. The normal population has periodontal issues. The normal population has TMJ issues. So if they come into thyroid cancer with that, somehow treatment for thyroid cancer will not make it better. And now we have this major change in our lives that now we blame everything on. And that's partially true somewhat, in that dry mouth only made those problems worse. But if you had bad oral hygiene to start, like I said, you're going to have bad oral hygiene once you're done. And that's just going to make a problem worse. So sliding a brush through those teeth, not a bad idea. Not a bad idea. Yes, ma'am?
Do you see any difference in the amount of radioactive iodine?
Yes. So the more, I think after 100 millicuries, it starts to get not dangerous, but we see more and more effects.
More of what you're showing.
Yes, ma'am. So after 100 to 150 millicuries, we start to see these kinds of issues, which is pretty much a standard dose. So we expect these issues in a lot of our patients. But again, all you patients are not a box, and they're not all the same. So like I said initially about the radiation, where one guy looks like he's totally fine and nothing's really happening, and the other person is like, destroyed and all kinds of pain, and they're not even halfway through. It varies. Every person is a little bit different. Every person responds differently to our standardized treatment. So, I don't know where you'll stand on that. You know what I mean? Maybe 150 millicuries isn't enough for you. Maybe you needed 200 or 300 to get that kind of issue. So very, very variable to a standardized treatment. And I think doctors have a hard time getting their minds around that sometimes. Even me, it's hard. If I give you something, I expect something back, and it doesn't always happen that way. Everybody reacts just a little bit differently. Again, daily maintenance, toothbrushing is a huge thing. Flossing, hugely ignored. Hugely ignored. Nobody likes to floss. I don't like to floss. But I do it because I want to keep my teeth. It's not good that your dentist has dentures, just saying. It's bad for business. So keeping the teeth clean is super important. And we know that if we don't floss, we're missing 30% of our teeth. So if all you do is run a brush through your teeth, 30% of your teeth are still the way they were before you brushed them. So there's no way to get a brush in between the teeth. Water picks are great for big things. And if it's the only way I can get something in between your teeth, I will advocate a water pick. But our gold standard is still floss. And that's the only way to get plaque out from in between your teeth. No $100 device is going to do that for you. String in between the teeth, get the stuff out. That's the only way to do it. Bland oral rinses, again, the baking soda, cheap, easy, and effective, will do a lot of the issues for us, or fix a lot of the issues for us. And fluoride, especially in the dry mouth, makes a huge difference. Huge difference. Prosthetic hygiene, again, can't be ignored. Just because prosthetic teeth don't decay doesn't mean we can now just forget about what we're doing. So keeping those things clean is super important. There's a big difference on how you do things. So we want an extra soft brush for your teeth, especially after radiation, especially after radioactive iodine. Nothing harder than soft in the general population, but for the dentures, things that come out of your mouth, we want you to scrub those guys pretty bad. So we want the hard brush on the prosthetic teeth, never on your natural teeth. Does that make sense to y'all? And now every company has their own denture cleanser, this Alka-Seltzer type thing for your dentures, and those are great if they work for you, but all you really need is a stiff brush and something to rinse it off with. So a little hand soap, a little dish soap will probably do just as good a job. So I'll tell everybody that. Again, this is probably why I have no conflicts of interest, because I say things like this. But yeah, hand soap, dish soap, something that washes off really easily is ideal in keeping it clean. We never want to use toothpaste on anything prosthetic, anything plastic especially, because it'll do two major things. One, it'll scratch it up, and that's not a big deal. But if you scratch it, then it'll give much more places for bacteria to grow, so that's the last thing you want to do. And you're scratching up my prosthesis, and I tell everybody that I make a prosthesis for. These are my teeth, and if you mess them up, I reserve the right to bring them back or take them back from you. So keeping them clean is a good idea. Saliva is much more than water, and I think I hopefully have established that. It's not just lubricant, although that's a big part of it. It's not just an acid controller, although that's a big part of it. It's not just an immune system component, although that's part of it. It's not just a digestive aid, but also that's part of it. Somebody brought it up to me yesterday that they're having digestive issues because they're so dry, and they recommended I assume it's some sort of probiotic that they get at GNC that helped them. I don't know anything about that other than what I've just told you all, so I figured I'd share that if you're having digestive issues. But saliva is super, super important. I think that list keeps growing, and I don't think we've seen the end of what saliva does. But certainly super important. Questions? Oh my gosh, yes. Yes, ma'am.
Speaking of the saliva, I know I've been tested, I had to do the spit test.
Mm-hmm.
And my saliva wasn't that bad in quantity.
Right.
So, but then we've heard the quality of it.
Quality is down. Quality is down for sure. So like I said, the very sophisticated cells that partially produce saliva, are really highly differentiated, which means it took them a long time to get to where they are. And then that makes them really super sensitive to anything. Medicines, radiation, that kind of stuff. So yeah, quality is decreased. And how much saliva you have, we know, makes no difference in your perception of how dry you are. So you can have, quote unquote, normal flow of saliva, but you can still feel dry. And there, again, we have no really good way to establish that. And that's why a lot of our dry mouth studies are a little bit unusual, because it's so variable. Does that make sense? So quality is definitely decreased for sure after this kind of stuff. Yes?
How do I go about finding a dentist that's knowledgeable about these situations?
You can look for a dentist just like me, which is technically my title is a maxillofacial prosthodontist. So that is kind of the cancer dentist, oral oncologist that we were talking about. So the I'm sorry?
Say that again?
The maxillofacial prosthodontist. So the AAMP, so the American Academy of Maxillofacial I don't know if it's prosthetics or prosthodontics, but I think it's prosthetics. They have a website. If you type in AAMP into Google, it's like the second or third one. The first one is the American Association of Meat Packers, and I still don't know why they're more important than we are. But they are number one on the Google, and we are number two. Or three, I think last time I checked. So that is the resource to find a prosthodontist or a dentist just like me. Most of the time, a general dentist kind of knows this stuff, because I'm not giving you anything earth-shattering. Fluoride is not new to dentistry. They just kind of have to be aware that this is an issue. Does that make sense? So a good general dentist should know this. But if not, AMMP is a good place to start. Does that make sense? Yes?
And also, would the dentist typically check or look out for signs of secondary cancers?
Mm-hmm. They're supposed to. Whether they actually do that or not, I don't know. So dentistry, again, is not, it's like medicine, you know what I mean? You get good doctors and that are really vigilant and take their time, and then others that, or just want to make a buck, so it's hard to say. But yes, they look for cancer. But with that said, you are, my grandmother says this all the time, you are your own best doctor, which means you know when something has changed. So don't be afraid to look in your mouth. Nothing's going to come out and bite you. And if you see something white, white patch, a red patch, a white and red patch, those are all things that need to be evaluated. Anywhere. Tongue, especially in the back of your throat. You can look just as quickly as we can. And your eyes aren't different than ours. So if anything looks different, that's the time to start telling somebody about it. Don't go directly to the MD. They'll tell you why they have a bad. They don't look in the mouth very often. So all they see is teeth and tissue. So a dentist, not biased against dentists, but we should kind of know certain things look like. And we're probably going to say, hey, that looks a little weird. Let's get that biopsy. Does that make sense? Yes. Yep. Right. Not at this point. No, sorry. That's the best we got. This was coming until I kind of first did your bubble, unfortunately. Not that I'm aware of. Other. Yes. To not be a negative Nancy, I'm not sure that it would. Radiation is cumulative, which means once you've gotten it, it's not going to get better. It's just that's where it's going to be. So, things may change where the body may get used to it, may learn to deal with it better. But will it get super better? I don't think so. It depends on where you are too. If you're really, the further you are from RAI, then probably the more likely you are to be better. But I don't think there's anything to do at this point that I'm aware of. Does that make sense? Sorry. I feel like the bearer of bad news.
It didn't show up for 6 months.
Yeah.
Radioactive iodine.
Yeah.
And it's been here for 4 months.
4 months. You're only 4 months after your silent endoscopy? And it's not gotten any better, huh?
It got better a month after for 1 week.
That's what we found, yeah.
For 1 week, and then it's been bad again.
At this point, I am not aware of anything that can make it better at this point.
Not eating pills.
I'm sorry?
Not eating pills.
No, that's not a good idea. But I have nothing great for you other than silent endoscopy again. Yes. Red, please.
At what point after radioactive iodine treatment
total I've had only 110 dental caries.
Mm-hmm.
But I have noticed a change in my dental needs.
Okay. Define that for me if you don't mind.
I'm sorry?
Define that for me if you don't mind.
More cavities.
Okay.
So my question is, can that be the quality of
Yes.
my saliva? And two, how do I determine, is there a way to determine if the radioactive iodine has something to do now with
Your cavity.
my
Yes.
cavities?
I don't. There's no test that I'm aware of that will prove that. We just know that teeth in a dry mouth will decay very quickly, and we know that radioactive iodine is implicated with dry mouth. So, there's no amount of testing that's going to make that any better. So we know that's an issue. So now we need to get you onto the preventative, which is our fluorides, and which is good brushing habits, which I assume you have. So the fluoride may make the difference. Does that make sense?
And I do fluoride treatments, and I go every 4 months.
And you still have issues?
Yeah.
Okay. Tell me about how you do your fluoride. I feel like we're doing a consult here.
Well, I do the fluoride treatment at my dental office.
So you do one treatment every time you go to see him.
Yeah.
That may be where you're falling short. One treatment every 4 months doesn't make a huge difference. So it makes a difference, but not a significant one in a dry mouth. So you may need to be on a daily fluoride regimen, either with a toothpaste or a topically placed fluoride.
Okay, so, and the other thing, and I've heard a dental oncologist talk a little bit in Dallas.
Dallas people don't know anything. I'm kidding.
I am an MD Anderson patient.
Okay.
So, my question is, the best way to test that would be to be able to set up an appointment while I'm down there for other things.
Uh-huh.
And
Your primary doc would have to refer you to us. So basically all you have to do is say, hey, I'm having some dental issues. I want to see the dental service. And your primary doc should be able to refer you to me or whoever, one of the 5 of us, and then we'll talk a little bit more about fluoride. So a topical fluoride daily applied is probably a good idea for you. So the one time, 3 times a year, once every 4 months is probably not enough.
okay.
Does that make sense? Yes, ma'am.
What is the amount of exposure of radiation through dental x-rays?
Very minimal, especially now with digital. So compared to what we're talking about with radioactive iodine, compared to what we're talking about with a CT scan, compared to what we're talking about with external beam, it's a drop in the bucket. And that has since decreased with digital x-rays, smaller fields, collimators, et cetera, et cetera, et cetera.
Dennis wants to do dental x-rays after, I just had my iodine treatment in
Yeah.
July, so it's okay.
It's absolutely okay, and it's that case that the risks outweigh the benefits. So if we don't take routine x-rays and see what's going on, then we can't prevent problems. If we can't prevent problems, then you're going down a bad road. So very small doses of radiation. Yes, sir.
Well, I'd like to know if there's anybody, excuse me, in here who has swallowing problems. And maybe we could get together and for lunch or something and gag together. See if we have ideas that could help each other, because that's it's a big time problem that I've had for the last couple of years.
Depending upon your institution, they may have a speech. That's depending on where you're going to get treatment. They may have access to a speech pathologist, and that's all they do is worry about your speech and worry about your swallowing after these kinds of treatments. So a speech pathologist may not be a bad place to go, assuming you know how to get a hold of one. Does that make sense? Yes, ma'am.
I'm sorry, we are out of time.
Oh,
so
cool.
Can I tell you thank you? If you do have any questions, can I come up and see you afterwards here?
Absolutely. Absolutely.
Thank you very much.